All right, today we're stepping right into the incredibly fast-paced, high-stakes world of the hospital ward. We're going to uncover what is, honestly, probably the most rigorous medical detective process in all of healthcare, the comprehensive nursing assessment. When a nurse walks into a patient's room, they aren't just popping in to say a friendly hello. No way. They are kicking off a really complex, highly structured investigation. It's a system designed to monitor the human body, detect completely invisible dangers, and ultimately save lives. So let's dive right in and look at exactly how they pull this off. So here's our investigative roadmap for this explainer. This is how we're going to decode the way nurses uncover these hidden clues. First up, assess, detect, act, escalate. Second, the A through G life-saving survey. Third, we'll do the systems deep dive. Fourth is vitals and the fifth vital. And we'll wrap up with spotting critical red flags. Okay, let's dive into this first section, assess, detect, act, escalate. Now, before we get our hands dirty with the physical techniques, we absolutely have to understand the big picture philosophy here. This is the overarching mantra that dictates the entire clinical workflow from start to finish. You see, patient care is never static. It's literally a constantly shifting puzzle. The golden rule here is that deterioration is dynamic, which means you have to recheck and react. Picture this. A patient is sitting up, chatting, looking perfectly stable at 10 a.m., right? Well, they could be in a total life-threatening crisis by 10:15. Because human physiology is just that unpredictable, nurses have to constantly recheck baselines. And the moment, the absolute microsecond, those baseline conditions change, they have to react and escalate care. And they definitely don't just do this all from memory. What you're looking at here is the literal checklist. This is the core guide nurses actually carry to structure everything, from their hands-on physical exams to their clinical handovers and their documentation. And if you look right at the very top, it proudly displays that core instruction we just talked about: assess, detect, act, escalate. It's basically the standard operating procedure for saving a human life. Moving on to Section 2, the A to G life-saving survey. So when our medical detectives first walk in and encounter a newly admitted or rapidly deteriorating patient, they don't just start checking random things all at once. Instead, they immediately scan for the most urgent, life-threatening clues first, and they do it in a highly rigid, specific order. This rapid response process runs systematically from A to F and then G for glucose. It goes like this. Step A is airway. Is it open and clear? Step B is breathing. What's the oxygen level? What's the respiratory rate? Step C, circulation. How's their blood pressure and pulse? Step D is disability, which means checking their neurological baseline. Step E is exposure, basically looking for any hidden rashes or wounds. And step F is fluids. Now, the absolute golden rule here is that nurses must stop and treat life threats at each individual step before they're allowed to move forward. Think of it kind of like a sinking ship. You wouldn't start worrying about pumping out the water if you haven't plugged a massive hole in the hull first, right? Same logic applies here. So the crucial point is this critical rule right here. After A through G, always reassess from A. This is where the real discipline shows. Let's say you apply oxygen during step B. You don't just move on to C and forget about it. No, you loop all the way back to the very start. Because like we said, human biology is super dynamic. This assessment loops continuously just to make absolute sure no new deterioration has started up while you were busy treating a totally different issue. All right, Section 3, the systems deep dive. Once that rapid emergency survey is totally complete and the patient is officially deemed stable, the pacing really changes. We actually transition from that fast emergency mode into a much slower, incredibly thorough, and highly structured head-to-toe investigation. During this deep dive, nurses use their senses in a really specific sequence. The standard order is to inspect with the eyes, palpate with the hands, percuss by tapping, and auscultate by listening with a stethoscope. But when it comes to the abdomen, that order completely flips. Why? Well, because palpating, or pressing down on the patient's stomach first, can actually mechanically alter their natural bowel sounds. So our detectives have to inspect and then immediately listen well before they ever lay a single hand on the patient. It's a small detail, but it's absolutely crucial. So, what exactly are these medical detectives listening for? Well, when listening to the lungs, a normal finding is a nice, clear, breezy sound called a vesicular sound. An abnormal finding, on the other hand, might be the high pitched, squeaky wheeze you hear with asthma. Or worse, a harsh, raspy sound called stridor, which points to a super dangerous airway blockage. And when percussing, tapping the abdomen, they're expecting to hear a hollow, drum like timpani sound over the bowel. But if they tap and hear a dull thud instead, that is a massive clue. It could mean unexpected fluid is pooling or maybe a dangerously enlarged organ.
This deep dive also involves some incredibly focused, localized checks. Take the head and face, for example. Nurses check PERLA. That's checking to ensure the pupils are equal, round, and reactive to light. They'll do a quick whisper test for hearing. They check to make sure the windpipe is perfectly midline, and they'll look for facial symmetry to ensure cranial nerve 7, that's the nerve controlling your facial muscles, is functioning exactly right. All of these tiny checks add up to establish a rock-solid baseline for the brain.
Moving into Section 4, Vitals and the fifth vital. Up until now, we've talked about what nurses see and hear. Now, we're looking at the hard data. These are the essential numerical tripwires that dictate exactly when it's time to sound the alarm and activate the rapid response team. Now, what's really interesting about this slide is this simple little threshold right here, less than or equal to 2 seconds. This is the benchmark for what's called capillary refill. It's so simple. A nurse will just press down on a patient's fingernail until the nail bed turns white, release it, and count. If it takes longer than 2 seconds for that healthy pink color to return, that is a lightning-fast indicator that the body's peripheral circulation is failing, and oxygenated blood just isn't reaching the extremities. Of course, capillary refill is just one early warning system. You've got your standard vitals, temperature, pulse, blood pressure, and oxygen saturation. But I want you to pay special attention to respiratory rate, which is normally between 12 and 20 breaths per minute for an adult. Clinical data shows us that a change in a patient's breathing rate is very often the absolute first sign of deterioration. Seriously, it can sometimes trigger the alarm hours before the heart rate or blood pressure ever starts to drop. But there is actually a fifth vital sign. And unlike a thermometer or a blood pressure cuff, this one is entirely subjective. It's pain. Nurses decode pain using this PQRSTU mnemonic. They ask the patient what provokes it, the quality of the feeling, the region it radiates to, the severity on a 0 to 10 scale, the timing of it all, and, crucially, the patient's understanding of what's happening to them. In this part of the assessment, the patient's self-report is the absolute gold standard. If a patient says they're in pain, period. And the detective work immediately pivots to figuring out why. Okay, final section here. Section 5, spotting critical red flags. Because throughout this entire systematic process we've been talking about, our medical detectives are specifically hunting for outlier data, the kind of data that demands immediate, life-saving intervention. A major hunting ground for these red flags is cognitive function, which is measured by the Glasgow Coma Scale, or GCS. Now, this isn't just some simple awake or asleep check. It's actually a really complex calculated test. It ranges from a minimum score of 3 up to a maximum of 15, and it evaluates 3 very specific areas: eye-opening, verbal response, and motor response. By putting all these together, nurses can document a patient's exact objective level of consciousness. And here is exactly why that specific score matters so much. A GCS score of 8 or lower is a massive, massive red flag. In fact, there's a pretty common saying in medicine: less than 8, intubate. Basically, if a patient hits an 8, their brain function is so compromised that the medical team has to immediately consider inserting a breathing tube just to protect their airway. What's more, any sudden drop of 2 or more points on this scale, that signifies rapid deterioration and means immediate escalation to the rapid response team. No hesitation. But what happens if a patient is wide awake yet suddenly becomes deeply confused? Well, nurses use the pinch me mnemonic to investigate the hidden causes of sudden delirium. They run through the list, checking for pain, infection, nutrition issues, constipation, hydration levels, medication side effects, and environmental factors. I love this because this brilliant checklist proves a really fascinating medical reality. A sudden psychiatric change, like delirium, is very often just a direct symptom of an underlying physical illness that needs to be solved. And this brilliantly illustrates the quick neurocheck framework that guides nurses through evaluating pupils, speech, and limb power. One critical red flag they are always watching for is a fixed, dilated pupil. Think about it. If the pupil isn't reacting to light, that is not an eye problem. That is a brain problem. It's an indicator of severe, potentially fatal issues, like raised intracranial pressure or a lack of oxygen to the brain, and that requires an absolute immediate emergency response.
So, we've walked through the rapid life-saving survey, we've done the deep dive systems check, and we've hunted for vital red flags. It is an immense, dynamic, and constantly looping checklist that nurses process every single time they step into a hospital room. So my question to leave you with today is this. Next time you're in a hospital, will you look past the basic routine and actually notice the highly structured, hidden medical detective work happening right in front of you? Thanks so much for joining me on this explainer, and keep learning.